like those who are not diabetic yet, they can take care of that. Those who are diabetic can do that and create the less intensity of the disease that they might get. Is there any prevention as a routine care that you recommend?
So I think everybody's mentioned some of those things already. It's, eating well more than anything. But if you're really going to talk about something that would affect every age group, it's eye protection. It's eye protection when working. I do a lot of treatment for ocular surface disease, meaning people that had alkali injuries, like they got cement or lye in their eye. It can cause massive problems to, instead of everything being clear, you get blood vessels and white tissue over the whole part of the front of the eye. I've so many times seen this in a 15-year-old that left school to go to work as a mason. And if that child had even worn safety glasses, he would be able to go back. And I mean, I realize he's not in school, but he's providing for his family. And that goes without saying about farmers, children that are working earlier. It doesn't really solve the 10 years and younger problem that I was talking about, but something as simple as protecting your eyes when working, which is a thing I talk about here all the time too. I don't think it's a India issue. It's a everywhere issue, but that could make a huge difference and a dent in completely avoidable eye problems.
Correct. Good point. Good point. So the prevention through protecting eye in certain activities. Any other thoughts from anybody? What can common people do routinely to take care of their eyes? Medical opinion, any kind of opinion.
Regular eye exams are always important. Sometimes people just don't go for a long time. I would say that, everybody right now asks, and I'll say this because we're on a computer, is like, is all this computer time damaging our eyes? There is no evidence of that. It's probably making our eyes feel a little drier because we blink about 50% less on digital media than we do normally. So I see people blinking now. So it's remembering to blink, and you can always use artificial tears if that should be a problem. But I will tell, since I see my dad, I will tell a joke that I've been telling people, because they always used to ask, is TV bad for the eyes? And he said, it might not be bad for the eyes, but what you're watching might be bad for the brain. So I would probably argue that might be the same case with what we're seeing on the computer now. It's not going to damage anything, but depending on what you're reading, it might be damaging for something else.
Thank you. Can you hear me?
Yes, we do.
Yeah. Well, this is Dr. Raju. I know what you are asking, that kind of a question. What else we can do? There is so much of misinformation about eye exercises. People, if you do exercises and all these problems will go, you don't need glasses, and you won't believe how many programs are there on the internet. Children with eye problems, certain problems, when they have, if we catch them early, give those glasses, and some exercises will help, not to make the eye muscles strong. The eye muscles are not like our biceps and triceps. The brain image in two eyes and making it one, that exercise is more to make two eyes work together. Once the 10th year or 11th year is gone, in adults, if you have after a stroke, after something, these eye exercises, and just doing after yoga, look to the right, look to the left. If it makes you feel good, anything, do it. That's okay. But if somebody is charging for each 15 minutes, 45 rupees, I think that's not right. So there's so many misconceptions today. I think if we can educate them, my mentor, I want to stop here by telling my mentor in London used to say, there are 3 solutions for every problem. 3 solutions. First is education, second is education, and third is education.
Yes, no, thank you for your comment. I think this, anytime it becomes commercial, charging 45 rupees or whatever for the eye exercise and stuff like that, anything that is prevention has to be part of the daily routine and should not require continuous paying money to learn or practice. And that is it should become way of life. And I encourage all this great work that is getting done through various organizations to promote routineness in creating a better habits that can prevent such issues in eye or healthcare. And that could be a big move itself and might have a better outcome going forward as a more like a fun society as opposed to a society that is poor and we are practicing sympathy and all that stuff, which is good. But I think we should begin to go after the prevention part, which doesn't cost money. Okay, thank you. Any other question? Uh,
Thank
Dr.
you for the
Raju,
opportunity to speak, and thank you for the invitation.
thank you. Everybody, kudos to the Raju family. Okay, so now we will move on to the third presentation. Dr. Nalini Saligram. She is from Arogyaworld and a Naperville resident like I am. And she's going to be talking about the prevention and childcare. And she has already made some comments. Let's get on with her presentation and learn some more. All yours, Dr. Nalini ji.
Thank you. Thank you very much for the invitation. And it's amazing how well curated your program is. Each presentation seems to build on the other, and it's really great. I want to piggyback on all the points that the others have made so far, including the latest comment on education, education, education. We believe very much in prevention education and in empowering people to adopt healthy lifestyles. And you'll see from my presentation that we have a lot in common with both Dr. Raju and Dr. Batra's work. So I'm going to start presenting now, and hopefully you will see my slides soon. Please let me know if you can see them.
It's coming through. Yes, we do.
Through. Awesome. Great. Good. Okay, so I'll go through this set of slides, but please interrupt me if you have any questions, and I really look forward to engaging with you guys and your comments. So we work in non-communicable disease prevention. I'm the founder and CEO of Arogyaworld. We're 10 years old as an organization. And non-communicable diseases are diseases like heart disease, diabetes, chronic lung diseases, and cancers. And these days, mental health is also included as one of the non-communicable diseases by the WHO. It's a really big problem in India. India is a diabetes capital, as we've heard before, but anecdotally, heart disease is really, one of the biggest contributors is India. And unhealthy eating is the #1 cause of death globally. If there's nothing else you remember, please remember this one sentence from this presentation. It's the food we put into our mouth that causes us to die. 80% of these diseases, the deaths are in developing countries. So this is not a rich man's problem. Even in India, 63% of the people die from NCDs, and in cities like Chennai, for instance, 75%, 3 out of 4 adults are either diabetic or pre-diabetic. And Indians get the disease very early, in their 30s, even 20s, even in school. This is type 2 diabetes, preventable diabetes that we're talking about. And the economic fallout is huge. Some $47 trillion is what the World Economic Forum and Harvard health economists calculated as the cumulative output loss by 2030. So we examined what are the reasons for this kind of huge global and India problem. Urbanization is a key force that leads to this. Modern lifestyles and convenience foods and, stress and commutes lead to this. Big tobacco and big food and their irresponsible marketing practices. A huge problem in India. There are very few doctors, very little, frontline health workers. So the health system is weak. And employers also can do more to improve the health of their employees. The good news, though, is that there is a solution, and we don't need a new vaccine. We don't need a new technology. We need to lead people to empower people to lead healthy lives. So, according to the World Health Organization, a healthy diet, exercise, and avoiding tobacco can prevent 80% of heart disease, 80% of type 2 diabetes, and 40% of cancers. So prevention is at the core of all our work, and we make prevention accessible. We have reached 5 million people in India to date with our programs. We take prevention to people where they live, learn, and work. We have programs like diabetes that I have mentioned, like my Thali that I have mentioned. We have a schools program reaching middle school children, and we have a very large healthy workplace program where we certify companies as healthy. We work all over India, and we are backed by a number of people. I am an Ashoka Fellow, but a lot of organizations back us. We get funding from not so many. we are backed for multiple years by RIST and Cigna, among others. So our vision is that all billion plus people in India lead healthier lives and thereby contribute to the best of their potential to society, and that the country meets its SDG indicators. Our programs, I want you to know, are, thoughtfully designed. I am a scientist at heart. I have a PhD in biochemistry from the Indian Institute of Science. So, showing that our programs are effective and have a base of science is a very key part of our thinking right from the get-go. So from a design stage, we have science basis. We also, work with experts, and we also show, or look for, sorry, I'll go back. How effective the program is. So this is our schools program. It's age appropriate. It's for 11 and 12 and 13-year-olds to teach them about healthy living. They're like sponges at that age. And we use compelling games and activities that are age appropriate to teach them, about making the right lifestyle choices. So reaching children before their lifestyle habits are fully set is a key part of our work. And this program is aligned with Ayushman Bharat's National School Health Curriculum. So this is our text message program that I had already mentioned. It's called Diabetes. It was a Clinton Global Initiative commitment from us. We fulfilled it. And we worked with Nokia to reach 1 million people in India from all over the country. We worked with Emory University to create the content based on science and behavior change theory. It's short messages, it's SMS that we sent in 12 languages to the million people. And we showed effectiveness, and it's been Northwestern University researchers were among those that helped us publish this data, really dug into the data, and we are really, excited by the potential for impact. Right now, this program is being done, as I said, has been completed also in the Arvindai community, and we have programs going on with Ambuja Cement Foundation funding and Lions Club funding in different parts of India, and we'll be starting with the LV Prasada Institute community as well. I'm most excited about one new potential partnership that is not quite signed, but is very close to it. And that is with Piramal Swasthya to take these messages to people all over India with, piggybacking on their infrastructure. My thali is, as I said, unhealthy eating is the number one cause of death. So we are very, very conscious about trying to change the eating habits of the entire nation. We really believe Indians don't know, most consumers don't know what to eat and in what quantities at every meal. So we copied the US My Plate approach, and you may have seen the picture of the, plate with 4 quadrants, 2 of them fruits and vegetables, one portion, 1/4 being carbohydrate, a piece of, a bread, and then the other being a chunk of meat, and then a glass of milk. So that's the American meal. We used their approach. We spoke to the US Department of Agriculture people, and we used the NIN guidelines, National Institute of Nutrition guidelines in India, to come up with this picture of exactly what a woman should eat and in what quantities at each meal. This is the picture for the urban woman who can afford to buy everything. And you can see, from what's at the bottom, for instance, salt is maximum 1 teaspoon of salt in the whole day. In the whole, all your meals of the day, you're allowed 1 teaspoon. Indians eat 3 or 4 or 5 times that. But what is our largest program is our Healthy Workplace program. India is average age or median age is 25, and the average working age of the working professional is 25. Our aim is to reach Indians before they hit 30. Because that's when they start getting these diabetes in huge numbers. So before that, we need to get them to appreciate and understand and change lifestyle habits. So that's why our schools program, and this workplace program is also reaching young Indians, as I said, are 20. Where do you find the 25-year-old in the working environment in the company? So we have a whole set of criteria that we have co-created with industry for workplaces in India. And we have used it now for 6 or 7 years, and it's divided into bronze, silver, gold. It's all NCD prevention oriented, but we started from scratch. We asked a group of experts, industry and public health, hey, what would mark a company as healthy? And all these, ban tobacco use, encourage healthy eating, these are the ones that came up. So we have those as criteria. Later on, we introduced a platinum level where we track metrics of employee health metrics. So this is important. And then there's a new level, Hall of Fame, which we haven't quite started. But of interest to you, we added mental health criteria for the first time. We worked with Harvard professors to create new criteria for the first time and added it to the criteria. So it is really amazing to me that probably India is the first country in the world to have a comprehensive healthy workplace criteria covering physical health, NCD prevention, as well as mental health. And we are really pleased with what we could do with these criteria and in companies. We are trying, we have a few companies that have already met the mental health criteria as well this year. So we have decent programs, well designed. We are showing impact. 15% in the schools program, 20% in the M-diabetes program, encouraging data in our platinum healthy workplaces. And we are working with Nielsen to do something to interpret the social media efforts we are getting with MyThali. But we looked at the systems, what is it that what contributes to the big problem of NCDs? And if you can see, there are multiple players and the really complex dynamics and very difficult power dynamics in the preventive health system of India. And I went through an Ashoka Globalizer strategy deep dive last year, and we examined, each of these equations, and we came up with 2 key players that we must focus on in order to make change, lasting change. And that is the consumer and the government. We realized that if we just stick to direct beneficiaries, we can only, we've got to 5 million, but we can probably get to a few more million. But if we get others and if we can influence others to do more of the implementation work, like the government, for example, then we can, exponentially increase the impact. So this indirect beneficiary stuff has stuck in our heads, and we are now focused a lot on what can we do with government and what can we do with the consumer. So our systems change one that we really worked with is is dictating all our work is how can we get the government to increase its emphasis on NCD prevention in all its programs. As you know, there are so many wonderful programs the government has done, but they don't seem to be focused on NCD prevention so far. So or not enough. So we are trying to increase that. And in the second system change that we're adopting, we want to build a movement around healthy living in India. And we believe that if we can get the consumer to be more responsible for their own health and motivate them, and if we get society to really reject unhealthy options, we can do this. And we want to use influencers, celebrities, social media influencers, and technology to drive change. So just a very short look at what we're trying to do with the government. We want to work with central government, state government, and city government. Um, this is a very complex slide and we can't go through all of this, but we are making headway at all three levels. Of interest to this group would be the Arogya City concept that we want to do in 2022 next year when India will be 75 years old. And that is to build this whole city, make Bangalore the first Arogya city and have a multi-sectoral summit and compare notes with San Francisco, its sister city, and then integrate that into the smart city initiative. So this is a very ambitious project and we're just about making the first step there. So if any of you, has any interest or would like very much to, I would like it very much if you can help us with some, advancing some of these things. We're also working with chefs, celebrity chefs and cricket stars, as well as using technology and using all these big partners to scale. Okay. So we have reached 5 million people so far, and our goal is to get to 22 million, educate 22 million people in India by 2022. So it's like 7 or 8 million people each year we have to reach this year and next year. So far, we also at the same time, so it's very ambitious, but also at the same time, we want to bring down costs because that's true scale, right? Expanding the program and bringing down cost per beneficiary. If you don't do both, then you're not really scaled. So we have raised 3 million and spent $3 million so far. So at about 60 cents per beneficiary, and we want to bring it down to 12.5 cents per beneficiary by the end of next year. So we have a small team of people. We're only, less than 20 people in that we, who are our consultants. But we have some good experts and advisors, and we have a really powerful boards both in India and in the US. So I'm positive we'll get there. But what I've learned today, from the programs that you have all presented already, it is quite amazing to me that we can actually piggyback on each other's efforts. So there are two particularly, efforts of ours that I want to emphasize. One is called a new campaign we're starting called Every Child a Healthy Child. So this is something we can piggyback with. People who are reaching children in school, our target age is middle school children. So if you've got efforts that are educating children in school for any other purpose, we can definitely piggyback on that. We'd like very much because our ambition is to get to millions of kids. And the second is make every village a healthy village. So, make rural communities healthy communities. So you're all already working in so many villages, and I would really like to piggyback on that because that's how we grow. We can't do it all ourselves. This problem is too big. Can't solve it by one entity alone. So but India needs us. Civil society has a role to play. And I can't sit when we're sitting on good programs with good results. It's very hard for me. I'm very restless, can't sit on it. So please, partner with us. We are eager. If you've got programs that are distributing eyeglasses, please, let's see if we can make sense and use that. If you're already in villages doing, vitamin A tablet distribution, I'd love very much to piggyback on that. And our nutrition program, we've adapted it for rural adolescent girls, because that 15-year-old girl is the one we have to educate before she gets pregnant, before she has babies, and before those babies, are born low birth weight and have diabetes and heart disease in huge numbers 30 years later. This is our core. Educate that 15-year-old girl in rural India. If I can achieve that in my lifetime at scale, I've done well. So want very much to work with you guys. I'm excited by what I've heard today. Last thing, we are working in Maharashtra to get to lots of school children. We've committed, we're signing an MOU with the Maharashtra government to get to 600,000 children using their Google Classrooms. And we have digitized our program, our school program, so that we can partner with all these groups. So if you have other groups that we can partner with with our digital program, school program, I would really appreciate that. Thank you. Thanks.
Has contacts all over India, and we'll be able to help you in whatever you want to do.
Right. Is that Dr. Jain? Was that Dr. Jain speaking? Yes. So Dr. Jain, I really, I feel with very little effort, we can actually make more headway, as your coalition. So I believe that. I think it's a question of, we can do the implementation if somebody makes the connects. And in your networks, if you all have...
Yeah. So we should be able to do that. And
Okay.
so please share your information. We are recording part of the presentation. I had some technical difficulties, so I couldn't do it in the beginning.
Sounds good. Yes, I'm happy to share the slides and we can take it from there.
Thank you.
One more request. If you guys, any of you has a friend or a colleague or acquaintance who runs a company or is in a senior leadership role in companies in India, please connect us, because our aim is to get to 400, 500 companies. We're at 145 right now. And we are partnering with Confederation of Indian Industry to get to more companies. But like that, if you have connects, if we start with the HR manager, it takes us a long time to get to company saying yes. But if we start with the CEO, there is a yes immediately. And we have both physical as well as mental health criteria now that can get a company to be truly healthy. That seems more of a strategic yes. So I would like very much to ask if you can connect us.
Yeah, we should be able to do that.
Okay.
So we'll do that. And we're working all different areas, and so we should be able to help. Okay.
Good.
And I'm glad everybody connects here and we work together. And thank you.
Thank you.
Jain Saab, may I make a comment? Can you all hear me?
Yes.
Yeah. This morning, we had actually 2 days, yesterday and today, the GAPIO, Global Physicians of Indian Origin. We are 1.3 million doctors of Indian heritage all over the world. Our level of the talking and all that is so different from this talk, about the prevention.
Right.
But all cure. That is, there was a beautiful, most wonderful paper 3 years ago, why prevention is respected, talked about, but not by people is resisted.
Yes.
This is all because there are so many things. I think this kind of thing, that's my interest. Just last month or a couple of weeks ago, there is a water wastage and all that. There was a conference and I gave a little address, though I'm an ophthalmologist, but still I'm interested in public health issues. Until you said, Nalini, you said in my lifetime, and you mentioned that so well, it's all may never happen in our lifetime until probably we start with the children. That may be one. And there must be integrity and basic honesty. In the leadership conference this morning, they said so wonderful leaders said everything, but the two words, integrity, honesty, did not come.
Right.
Pleased me.
Right.
If we have political will, professional will, and people's will, it will change. Otherwise, we keep on doing all this fractionized. There are probably how many organizations are doing for the last 25 years plus.
Right. See, prevention is very hard. Each one of us knows about healthy living, and COVID has made it even more important. You know, if you have underlying NCDs, if you have obesity, you have underlying hypertension or diabetes or heart disease, you're going to have much worse consequences from COVID. So, the silver bullet is healthy living. You eat right, you exercise, you can do wonders to yourself, to your community, as well as prevent the, make the world stronger to resist the next pandemic that comes along. So it's very clear to me what we have to do, but it's very hard. And the what drives me though is that you can't treat your way out of this non-communicable disease crisis. 4 billion people in the world are living with NCDs right now. 4 billion. How can you distribute medicine, cholesterol medicine, to everybody who needs it? How can you ensure that all of these people get all the medicines they need? It is really impossible. It's a very big treatment, is a very big challenge. So you have to cure, you have to prevent, because then you can, you have less and less people living with NCDs, and then it makes sense. So for us to leave the world more sustainable, for us to leave the world a healthier place, prevention for me is the smart solution.
Yeah, most modern technology, pharmaceuticals, everybody boasts about, added about 8 years of life. That's all. We are all living longer because of preventive aspects that happened almost 110 years ago. Winslow, I presented that one I was talking about last week. The preventive aspects brought us our longevity in our life. All the most modern medicines are giving another 7 years of life. That's all.
Mm-hmm. Good. Thank you. Yeah. Ms. Bharat, you have a question, comment?
Yes, I do. I have a request from all of you, actually, the speakers. It would be great if we can have contacts.
Yeah.
I'd love to be involved. As I said earlier, my focus is ending malnutrition in India. To me, malnutrition is at the kind of base of all of these issues that we talked about. And, India is the world's largest malnourished country in the world. And so it'd be great to connect some of these wonderful ideas and programs that you have that have spread out and connected. And if you could tie in models that seem to be extremely successful. If I have a minute, can I tell one quick story about a health worker? This is health worker in Palghat in Maharashtra, in a tribal area where there's extreme malnutrition. He lost, his wife, they had 2 children that were stillborn. And he was a health worker. And so he wondered, why is it that I cannot have children? And so he had all these, and that was the time when there were all these deaths of children. And so the ministers would come from Mumbai and give them grain and food and all that to kind of appease them. And, they were not very happy until these workshops started, where all the health workers were educated about nutrition, about various stages of development, all the way from the first 1,000 days. So he took it to heart. His name was Kailash. And he wrote a wonderful letter after the workshop saying, I get all this assistance from the politicians and leaders, and they give us money. And he says, we are not poor. We work hard. We are not begging for anything. What we want is knowledge. If you can tell us what we need, and finally we have learned that. Well, since then, he's had two of the most wonderful children because he got his wife going into right nutrition and everything and so on. And on the World Health Chart, both of his children are in the 10% percentile. And this kind of thing is happening in all of the villages where they go through these workshops and so on. And so I think we have to start in, especially in India, where we have so many children born. One of the reasons I think India cannot reduce its malnutrition rate is because with all the improvement and all the support that's given to the children, every year we have, I'm not sure exactly how many, hundreds of thousands of new babies born by mothers who themselves are malnourished. So we never end the supply of the infant that's not properly nourished at birth. And so we have to start at that stage. And I agree with Nalini about starting with the village girl. I think I would add to it an urban girl too. City girls are not that informed either. Anyway, thank you so much. It just I'm just passionate about it, and I'm so happy that you all are doing it, and I love to participate in making it wider and bigger.
Thank you.
Dr. Desai, we can't hear you.
I can't hear you.
Dr. Desai is on mute.
He's not on mute. We just can't hear him.
No. No, can't hear you, Dr. Desai. Your computer, can't hear you.
It's probably still connected to your Bluetooth headphones.
Correct. So some. No, we can't hear him. Dr. Jain, we can't hear Dr. Desai.
And
May we suggest that we get Satyendra to speak, because we can probably hear him while we sort out, the introductions. Maybe you can introduce yourself.
Sure, I'm happy to.
Is everybody okay? Shall we start? Because we can't keep, we lose people.
I think that's a great idea.
Yeah, go ahead. We give you permission.
Thanks, Dr. Saligram and Dr. Raju. So let me share my screen. I hope you guys seeing the screen.
Yeah.
I think, okay. So thanks to Dr. Jan and everyone else who's present here for this opportunity. I couldn't echo more with all the presenters, Dr. Batra, Dr. Shaligram, and Dr. Raju. The extent of what has been done in India and the willingness and efforts of all of us is actually very important. You will find my presentation is a little bit different, and probably some platform which could be useful or maybe able to bridge the gap which we are seeing. So before I get into what we are trying to achieve in India, I just want to give you my background. So I spent around 8 years at Northwestern Medical School as a faculty member in health data technologies. So I was able to build a lot of infrastructure, national and regional level. And what we realized when we are building using the technology to bridge the gap, the problem was never technology. The problem was the approach in developed world or the Western countries, which is basically system-driven approach. Whether it's either provider or health systems drive the care or payers drive the care. The patient we found at the very bottom or at the last stakeholder in the entire care given spectrum. So keeping that in mind, looking at India, what we decided and my efforts being driven in, can we build something different in terms of healthcare, prevention being the focus, is the what we call individual up or the user up. I don't call them patient, just the users, because I think healthcare belongs to everyone. You don't have to be a patient to be part of the care spectrum. Keeping that in mind, our mission was similar to all of you, education first, but we extended that to education alone in India will not work. But education is required because we are looking to change the culture entirely. Education, we move from education to awareness and then facilitation. So we move in education, awareness, and facilitation, keeping those three mantras in mind. We realize the India is diverse country. The walks of life is so diverse that to reach out to all 1.3 billion people, one single solution, if you try to approach, will not work. We can target the bottom of the pyramid. We can go to the top of the pyramid. It's just a business decision. For that reason alone, India Health Link is not a nonprofit. We started it as a business because I wanted to use where my expertise are the best. And we trying to approach the situation in two different ways. One, we're building a connected digital platform, basically a platform where everybody can have their own health account. Similar to you have your bank account or email account, you should have your own health account where you can get access to any services you need, whether again a diabetes care, the education about any other any of the mental health situation, or even curative services. You should be able to get to all of those services based on your own profile, what we call your own persona, because I think there is no one size fits all solution exists. So everybody have different needs. Everybody has different the environment they live in. So everybody should be able to get to what they need based on their own profile. The second part of our solution was healthcare always will remain, whether we talk about NCDs or any other disease, healthcare always remains touch and feel. Unless people know that they're talking to somebody who can tell them advice or give them advice, they don't actually consider that. They themselves don't want to consider it validated. So keeping that in mind, we went on what is the most important parameters or information we want on individuals is basically vitals, whether it's NCD recommendation suggestions, whether it's telemedicine or even curative medicine. If we can provide some way, shape, or form, a mechanism for them to measure their vitals and keep track of it, I think we can provide that. We can increase the effectiveness of services we want to offer. So with those two in mind, I'm just going to cover what we are, how we are trying, what is it, what we are trying to offer. So on the device side, we were in last 6-7 years, we took a solution from US and we built it in India for Indian population. This is a self-operating, non-interventional, non-interventional, no human, I would say, the assistance required, a self-operating healthcare kiosk. The kiosk does the most basic vital screening, but also does some of the screening like ECG, 6-lead ECG, which is good enough for at least early diagnosis of heart issues. It does the full body BMC, temperature, SpO2, blood pressure, etc. That is around 95% of the readings you would need in terms of vital screening. But in addition to that, that was not enough. You can have those the vital screening done in many ways. Why we have why we decided to have a kiosk is because accuracy of these readings are vital as compared to just providing something which is non-attached, that anybody can do it on their own convenience. That is the biggest issue. People always get the readings wrong. So that is why we have the kiosk, which is contained and validated to be able to get the right readings. We have all other things which makes it more useful: local language compatibility, audio video integration. It has the fingerprint reading. So if you are in India, if you're not literate enough, you cannot read it, or you can't even respond to it. It's a text and the speech both are there, but also is integrated with your fingerprint, so you can access your records previously if you have used the same system anywhere. With that, we are trying to say, can we build a new kind of healthcare system where everybody is connected? It doesn't matter where you live, doesn't matter what your economical or physical situation is. You should all be able to connect to the single system, which is driven by individuals and built for individuals. And as I mentioned, the device is one part of it, but we are on the other side. We have the very robust connected system. So whether you use our healthcare kiosk, or we also have mobile app, or the web, any kind of web platform, they're all connected in one in seamless way. And once you have an account, you can do your consultation or readings or screening anywhere you find these systems. Whether you are going to office, you're in a housing society, you go to bank, gym, hospital, anywhere, you should be able to get to it. In the rural model, we are looking into, can we connect with panchayats, and can we train local healthcare, community health providers, or even just general population to be able to operate these. This is just the same idea. Our main perspective is to build a platform and connect everyone to it. On one side, we are saying all the users should be able to have simple account. They should be able to measure their healthcare vitals. They should be able to also provide inputs on what they eat, where do they live, and we can provide a communication from that angle, that they can connect to anybody in the similar situation they feel comfortable talking to, right? So that's one part of it. But on the other side, the platform is open-ended. So we are not building all the services ourselves. As Dr. Saligram said, we cannot do it alone. What we have done is we have made the platform integratable. So any services, any non-profit organization, any NGO, any for-profit organization who is providing any kind of services can be on the other end integrated to our platform. Now it's always on the user to be able to connect to them, be able to use and select who they want to communicate with, what services they want to avail, whether it's free, whether it's on payment. What our motivation here is, we do not charge users for using our platform. And if something is free on the platform, on the other side, like all of you are offering these services, beautiful services, or the facilitation which you're doing, if they connect to them and they don't pay for it, they don't pay us anything. So in addition to what we are trying to provide from the third-party vendors or the services, we already on our platform do a very basic level of what we say in our education, awareness, facilitation. We also have make people healthy and keep them healthy. That particular mission, we actually do some analysis based on their own vitals we are collecting and start sending them some recommendation, like My Thali, as Dr. Saligram mentioned. We have a little bit different way of looking at it. We provide them recommendation what to eat and what is good for them. But what we are thinking, maybe it's also essentially or equally important to ask them what do they actually eat, so that this is a recommended diet, this is what they actually do, and then based on what they actually do, maybe we will be able to move them a little bit forward in towards a healthy diet. Because we didn't find, in India at least, that there is one single diet we can recommend to people. We have a database of I would say hundreds of thousands of options. So based on what you do, we are able to use the power of technology and data to get them to that where everybody can get the diet in their comfort range, so that can be healthier for them in their own environment. Also, another essential part of it is because we are all digital platform oriented, we have our own analytics portal. And the analytics portal is the entities who sign up for it, whether you're a corporate entity or an NGO who work with us or something who's farmers oriented. You are able to actually not only provide the services, you're also able to see how the impact is being made. As there is this program of certifying organization in terms of how they are doing for their employees, what we have is we have health score for every individual based on where they are. We are trying to motivate them to become healthier, and their health score basically measure that how much efforts they are putting. But we also have organizational health index based on if they sign up for it, based on their own stakeholder population, whether they're 5,000 employees, 500 employees, or 10,000 employees. We can tell them how they are doing on an average in terms of their employees' health. We work with individual employees, but we provide data and analytics on the corporate level. So I think just in the sense of time, I'll just keep moving faster here. We have spent around 7 years to make sure that whatever we are offering in India is basically state of the art. So everything which we have in terms of devices, they are FDA or CC approved. We also ran a big clinical trial locally in Mehta Hospital to make sure that our readings are at par with the clinical readings. So these are the current, we have a lot of affiliation in terms of the deployments. We are providing a platform in the middle. We are not at the forefront of the users, but we are trying to, because this is such a big task, and India is a huge country. We cannot be on the forefront. So we try to collaborate with other entities who can actually take us to their stakeholders. We just make sure that we make it simple and easy. Our cost of use per user is less than 10 cents. And we can keep that going just because the scale is what makes us cost effective. We also have collaborated with the clinical care in terms of telemedicine, the medicine delivery. All of that is available, integrated with us, but it depends on the stakeholder. What do they want to make available to their population? With that, I think the last one is we are working with government. We are one of the Smart 50 selected solutions, basically, which can transform India. And our main intent is to stay in the middle, empower the user with the help of, and provide that access to the users, to every NGO, government, for-profit, hospital, anybody who want to provide services to them. So I'll skip this one, and thanks again for giving me opportunity to speak here. Again, I think everybody who's talking here has the same intent in mind as we do. The only difference here is I'm trying to look into how can we change the way healthcare is delivered and perceived, and we try to make sure the user is always the starting point, not the system itself.
Okay. Thank you. Thank you, Dr. Goel. Appreciate your presentation. Can you hear me now?
Yes.
It doesn't.
We can hear you, Dr. Desai now.
Can you hear me okay?
Yeah.
Yes.
Hello?
Yes.
We can.
Good. Thank you. Thank you. All right. So I had some difficulty signing in and out, and some probably it is solved now. Thank you, Mohanji, for continuing the process. I open it up for the question, but I want to make a first comment about all four presentation. And in order to move things forward, I'd like to share a couple of ideas that has been bubbling in my mind for some time. There are a lot of point efforts going on in various organizations with passion, and they are doing excellent job. The key is how do we get ahead in terms of achieving so that the entire society or the nation make quicker progress as opposed to something like going along the line and not changing the effect as our passion should bring it out. So the many presenters talked about the psychological aspect or the people's mindset, and then creating venues to fix the problem, prevent the problem. I think what we need is a massive mindset of people to get into the new habits, the right way to do that, and be more health conscious. The indexes, the indicators that Dr. Goel mentioned, excellent. Like everybody measures their wealth by type of car they have or the bank balance they have and kind of clothes they wear. We should have a drive by which they talk about their health as an achievement. And that should be the norm in the society, that health is just as good an indicator as the wealth that anybody possesses. So, with that kind of a thought, trying to make some fundamental changes of mindset change, that creates the behavior change and that creates the outcome. And maybe there is a need for science, as Dr. Raju mentioned, that it only added 8 years with all this kind of preventive lifetime medicine people take for cholesterol and stuff. I would think that if you go with a good preventive aspect, that can add a lot more than 8 years, lot quicker. And India being in a forefront of an ancient aspect of living well, perhaps we may have to get into something more strongly into the prevention, mindset change, and creating a health index that is equally important, like people having money, night dress, houses, and the car. With that, I open it up for the comment and questions.
I'll start. So the machine is really interesting because of all those parameters that it can give the user. I was just curious, is there a capacity to check vision on it?
Yes, it is. So Dr. Raju, that's one of the main thing which we are lacking right now. The reason is every time we integrate something, it takes us a long time. So we started with we took blood pressure and BMC was height and weight was already there. It took us a year and a half to get the ECG working, even though you know how difficult it is to get all the ECG, which is 6 lead, but it's working now. And our main motivation was non-invasive, non-interventional. So you don't require a paramedic to be able to operate that. That is why it took us a long time. But vision is next. Right now, it is easier for us to do any software screening. So if somebody has like an image-based or any kind of algorithm-based screening, color blindness is easy. But if you want a sophisticated optical device, we can do that. That is our next step. But right now, anything to connect with like collecting data, surveys, where you can easily screen who is in the need of the services, we can do that today. Right?
G2 this, I'm having significant issue with this audio part of it. I cannot listen well. I hope you listen to me, but you may have to conclude this session at the end.
Easier to do right now is if you are at a high BMI, just remind them that they need a dilated
You can
eye.
hear me, but I can't hear other people well.
But exactly
So
what we need, right?
I
So we
can
need to
keep on
connect with
going.
like your organization or somebody who
Thank
can provide that recommendation. So easy for us to send it to the users. But we just right now starting the point is we have connected the users. We have data on users. We can provide the recommendation based on whatever algorithm you want to specify.
So, Dr. Goel, again, picking up on your kiosks, they are fantastic. I actually know someone else who's doing similar ones in shopping malls in Latin America. I'll try and connect you. But how many such kiosks have been deployed so far, and how many of them are in corporate India? You know, we have access to 145 companies already, and we want to get to 500 companies by end of next year. So, you know, again, a very real collaboration is possible. But you know, what is your reach right now?
So again, it took us a long time to get where we are, but then COVID hit. So we had around 25 kiosks, and they were multiple. They were some of them were in farmers organizations, farmers entities. Some of them in the NGOs in the community. Some of them are with the corporations. But now COVID is getting a little bit better in some situation. So our goal is within next 3 months, we'll have another 25 to 50 deployed. So either because our scale is fast, and the idea here is you're basically looking at what we call a mobile primary healthcare system. And once you put into the community, it is there, right? So it's like a simply said, it's such a small, low touch hospital system, which can provide the last mile reach to most population, whether you're a patient or not, right? And the cost of care is so low, like what we charge is 25,000 rupees per month as a leasing model to the kiosk, and that's it. There's no other cost. No other cost of any user who get access to our platform, digital platform systems, that is at no cost.
Right. And in your surveys or in your index, when you calculate for corporate, let's say for corporates, or even for individuals, you calculate their health score. Do you use behaviors also, or it's just the actual cholesterol numbers and objective measurements?
So it's a 5 different segments. So exactly as like it's a simple thing which everybody is doing. We collect vitals, which we collect ourselves. We collect their dietary habits, lifestyle. We take environmental data, where do they live, and we also have social aspect of it, how happy they are, how many people they interact with. So it's a scientific. Again, I'm a PhD as well, so it is all scientifically driven health score. So our highest is 1,000. Nobody will be able to get to 1,000 because that doesn't happen. But the idea is we give you a basic health score where you are, but then we provide you programs and facilitation to be able to improve your program. So more often you take care of yourself, more often you take normal challenges like walk, talk to people, socialize. So again, so the health score itself is built out of 4 different segments.
Have you found it difficult to maintain the machines when they're in a more rural area? I'd ask this because I mentioned the telemedicine things we're doing in the NICU. That machine it's still pretty sensitive because it's a really good camera. And we're taking it around in a van, and there are times I wonder how they're doing that on some of the Indian roads. But I was always wondering, like dust, just higher tech equipment in more rural areas can sometimes be difficult to have everything continue to function the way we want it to.
That's exactly right. So one thing which I tell my people, it's a perfect machine for any environment. We have made sure that works, but you cannot put it into the van. You can't put it into the van. It's perfect for the camps, but it has to be stationary. Just because every time you move, exactly what you said, there is so much sensitivity devices, and a small change, just change the BP. I can't take any more BP correctly. I cannot give you right ECG just because that is just so sensitive, and it is difficult to understand until you have that clinical knowledge that how that variation actually matters. We are able to make sure that you put into any environment, it's a steel, 100% steel, nothing is exposed, all sensor based, and what is exposed to is a very hardened sensors underneath. There's always a surface on top of it. So dust and the operation is no problem. You can run for 10 years. Our oldest machine is running from last 6 years and with no issues. So it's 100% remotely managed. We run on all we need is electric signal and a cell phone or a Wi-Fi or whatever internet. So it's 100%. It can run without network, but there's no issue of non-functioning of the devices. You shouldn't just keep moving in a van. It wouldn't work. So I think we lost Dr. Desai again. But again, I would like to thank everyone. Dr. Bharatji, go ahead.
I have a question. I'm
Go
wondering,
ahead.
unfortunately, because of COVID, I'm not in India right now. Normally, I'm in India at this time of the year. Maybe next year I'll be there, or in the fall. Is there any machine like this set up in Mumbai? Where in Mumbai? Because I'd like to try it out.
Sure. So,
It's very interesting. And I know number of places where something like that would be very useful. But I'd like to have some experience in it. And also, if you have some data on outcomes where you're already set it up, I would love to see that. And because that's something I can pass on to other groups that I work with, and maybe they might be interested in.
I can give you simple data. As everybody's talking about pre-diabetes, we have for 50,000 people tested on the system, and we can tell you around 70% of Indian people either are diabetic or pre-diabetic. And I'm talking about people who are in corporations. The 25 years older, they are so stressed. 50% of them have higher hypertension. They have hypertensive, and they have obesity or that problem. It is already there. I mean, and our system is live. I can tell you on everyday basis, every kiosk, what's the average aggregate data look like. And to your first question, we are in Delhi, Maharashtra, Pune, Bombay, Bangalore, a lot of places. So if you go to indiahealthlink.com, you'll be able to see every kiosk in their location. But also, happy to connect. And whenever you are traveling, I have 20 people in India who work in the company. Happy to take it forward from there.
Very good. Thank you. Thank you. I have a couple of quick questions to Goelji. One is you have kiosks through which you collect data. You mentioned 70% and hypertension and stress and all that stuff. Is your technology can transition in some way to the smartphone? Collecting data might be an issue, but you can use the widespread reach through the smartphone. That's one comment. The second comment is I think we during this 4 presentation, we know we have a bunch of issues. We have some solution. We have point solution and curing and prevention and all that stuff is happening. The synergy amongst this presentation as well as synergy to look forward more acutely rather than solving current problem is our singular focus. So what we want is a society which is more healthier by percentage as opposed to solving the issues. We need both efforts. And so the prevention side, the habit side, mindset changes, and all that stuff, I think we have relied, and rightly so, by modern science and the culture that we all in the Western countries have adopted. But there is a very strong other body of knowledge, which is I call ancient science, good habits, good eating, good relationship, contentment in life, the purity of thinking. All that stuff is also, I call it an ancient science. People call it yoga and Ayurveda, but I think there is a science. Our culture live in a different world than the Western world. We will never be replicating the Western world in India. So all of our efforts, I think if we should be able to magnify what I call ancient science in our effort to increase the good living and the mindset, contentment or purity of thoughts or caring for others, and that becomes widespread. And there may be some indexes that indicates what person is on that indexes. So I see a nice little shift from the very predominant Western effort to beginning of Eastern effort to blend, especially for India. I think it's beginning to work in US too, given the mindfulness and all that stuff is catching on in the society. So any thoughts from audience about this, mixing these two approach and going more on what I call ancient science as a way to accelerate?
Dr. Desai, I just mentioned for everyone, we are not we are not a system for allopathic medicine. We are a system for individuals. So what you call ancient science in holistic care spectrum, we are IHL care. We don't call ourselves a hospital system. So and we do have a digital platform. We actually are considering, or at least have that open to all kind of facilities being provided by, let's say you are a yoga, mindfulness, mental happiness, whatever you're offering to our users, we open that platform to everyone. We don't have, when you go to we do have a mobile app called IHL Health, but it's only available in India. It's not in US. So if you go to IHL Health, the device is not our main offering. Our offering is to build a platform for users. You can have your own Fitbit, you can have your own blood pressure device at home. You should be able to get to the same access which you will get through our kiosk.
Correct.
So just go to IHL Health. We are now onboarding people who provide happiness training, mental health counseling, even the Ayurvedic. All of that is open in our platform.
Very good. Thank you. I missed some part of it during the audio problem, but thank you for the clarification. Any other comment from any of our speakers or the audience?
Yeah, I would like to add to this. Can you
Okay, go
hear me?
ahead. Yes, we can.
Yeah, I am from Maharashtra, Latur. I am the president of an NGO run by women and run for women. So I agree with Nalini that it should start with the adolescent age group girls to make them aware about the healthy type of living. That's what is our experience, that many the girls who went to school, they don't even eat breakfast. They just take tea and they just go out and they eat their lunch at 1 o'clock. So that was the habits, and we are taking awareness programs in all the adolescent age girls, and that's what we are trying to change them, that try to eat something at least before you leave for the school. So that is how is the habit of women. They are even women are also not accustomed to eat properly. So that is the main problem. That's what I feel.
Yes, good comment. Good comment. Any other comment, guys? Okay, so we are just about ending our conference today, and before we end, we would like to end in a note that enhances our individual efforts and intentions. And for that, I'd like to observe what I call mindfulness for about 30 seconds. Everyone should reflect on what they are getting out of this conference and what makes a significant change going forward in their own thinking. Thinking being not necessarily enhancing your own ideas, but something different that you're going to do as a result of this thing. And it's just simply reflection. You have to internalize. We are not going to ask you what was that, but it's just to anchor down into doing even better as we go. So I'll do one little sound with this. We start. Close your eyes, be comfortable. Just reflect and feel very anchored in your own self to do something different, something positive, something groundbreaking going forward from the learnings and the contact we have established in this conference. Thank you very much. Appreciate everyone's participation, especially the presenter, very passionate presentation. And as a result of these couple of hours we spent together, we all have improved our point of view, point of thinking, motivation, and be happy, be content, be what we call santosh. And that brings the life to a different level of peacefulness. Thank you, and kudos to everyone. Mohanji, over back to you. Mohanji, any parting thoughts? No. I think he's trying to come, but all right. All right. In interest of time, we would close the session. Thanks again, and until next time, have a great time.
Thanks, everyone.
Thank you.
Thank you. Bye bye.